Jack West, MD. I'm an associate clinical professor in medical oncology at City of Hope Cancer Center in the Los Angeles area, and also founder and president of GRACE. Isabel, can you tell us who you are and what you are?
Sure. My name is Isabel Preeshagul. I am a thoracic oncologist at Memorial Sloan Kettering, and I am very excited to be here today speaking to all of you.
And Joan.
Yes, hi everyone. I'm Joan Schiller. I'm a medical oncologist living now in Northern Virginia. I was formerly the deputy director of the Cancer Center at UT Southwestern and also of the Shar Cancer Center in Northern Virginia as part of Inova.
Excellent.
I'm glad to be with you.
Let's turn to a new target. Another new target that we have is EGFR Exon 20. Now, we've been focused on EGFR as a mutation for 20 years, but the ones that we have far more experience with the common EGFR mutations on exon 19 or exon 21. Exon 20 is an uncommon mutation, and it's been pretty challenging. Most of our EGFR inhibitors are not particularly effective for that. And there's now a therapy called Amivantamab or Rybrevant, which is an IV medication that targets this and has a response rate of 40%, but does have some side effects, rash and infusion reactions. My experience with it is really too limited to say much, but it's out there. And I would say that this is an agent that is not approved as first line. It's approved for after prior therapies. And with a response rate of 40% and some side effects, is not one that I feel is a real mandate to move into the first line setting. Can you both comment on where you feel this fits in? And I'll also mention that we have another agent called Mobocertinib, and I'm trying to recall what its trade name is. It was just approved. But this is a pill-based therapy with a response rate of about 27%, and also with issues of rash and diarrhea. So none of these agents is a free ride in terms of side effects. They do have activity, but they're not astonishingly effective yet. And so, where do they fit in and how do you prioritize one over another? We have now two agents in rapid succession. Previously, up until this past year, we had none. So, Joan, how do you see integrating these into your practice for these patients? And, how often do you see these folks?
Yeah, don't see them very often at all. I think one of the things about Amivantamab, though, is it has a relatively unique mechanism of action.
Right.
And so maybe
that's what's a bispecific antibody. So it actually binds EGFR and MET, which is another target. Yeah.
Mm-hmm. So maybe we will get second or third generation of drugs like that will be able to improve upon this. But I agree. But, given how effective some of the other targeted agents are for EGFR mutations in general, 19 and 21, as well as for ALK, this is disappointing that it's not more active, but we can hope that we're going to get more active agents with time here.
Yeah, I guess our expectation for a targeted therapy is a response rate of 60, 70% or higher, good responses in the brain, and often we've been spoiled by low toxicity, and that's just not, we don't have anything that clean in any of these right now. I think that there's something, and I know that my few patients with an EGFR mutation EGFR exon 20 would take it, but it's not the home run we'd hope to see. Isabel, I don't know if you've seen many of these folks at Memorial or what your impressions are.
So I have actually inherited a large exon 20 cohort of patients, and I'm excited that we have something because they have been left out, from their exon 19 and exon 21, EGFR mutation patients. they don't get the same benefit from osimertinib, as we know. Even the double dose osimertinib dosing for these patients that was previously presented. So I'm happy that we have something, and I'm happy that we also have mobocertinib, but I agree that it's not a slam dunk for them. And the toxicity is not something to ignore. It's real. The rash is there, the infusion reactions. It can be scary for those patients. And I think there's the right patient for this drug. And I'm wondering more and more if perhaps that MET that you had mentioned, Joan, perhaps if we have resistance to frontline therapy is because they've developed a MET resistance alteration. Perhaps those are the best patients for amivantamab.